second presentation. I'm really pleased to have the pleasure of and the privilege of having Dr. Matthew Brown from Royal Marsden. He's a consultant in anesthetics and pain medicine, and he is very well known in pain medicine world, and he is a member of Professional Central Committee for Faculty of Pain Medicine, and he is also interested in cancer pain, where he is involved in research, leading research on MR-guided focused ultrasound. And he has written several book chapters, and is also national lead for a cancer pain pilot in the UK. So he's going to present, now he's on holiday at the moment, but he's going to join for Q&A session after his recorded talk is completed. So we'll try to share his talk and see how it works. So I think Lorraine from Pain Relief Foundation is now going to share and start his talk.
My name is Matt Brown. I'm a consultant in pain medicine at the Royal Marsden Hospital in London, and you're joining me today to listen to my talk on cancer survivors and pain. So I've got 20 minutes to talk about a pretty huge topic. So I'll do my very best, and I'll also be appearing for questions at the end of this talk. A bit about the hospital where I work. Well, the Royal Marsden Hospital was founded in the middle of the 19th century by a doctor called William Marsden. His wife unfortunately died from cancer, and this inspired him to establish a hospital whose sole purpose was the research and treatment of cancer. And you need to remember at that time that cancer was very poorly understood, and we were very restricted in the treatment options available at the time. The hospital has gone from strength to strength over the decades, and in conjunction with our partner academic institution, the Institute of Cancer Research, we are now the largest comprehensive cancer centre in Europe. I'm going to talk about the definitions and changing landscape of cancer survivorship, and then focus on pain that arises both due to disease, but also due to the treatments which patients undergo for cancer. I'll also touch briefly on management approaches, and I view this talk, due to its brevity, very much as a signposting exercise, and certainly if anyone's interested in any of the areas that I've touched upon today, my email address is at the start of the talk, and I'd be very happy to be contacted for any further information that's required. So why is pain in cancer survivors and, in fact, in cancer patients full stop important? Well, when you talk to cancer patients, pain remains the most feared symptom following a diagnosis of cancer. And we know that pain is common in patients with cancer. Around 2/3 of patients during treatment, about 1/3 after curative treatment, and around 2/3 again with advanced cancer have moderate to severe pain. And we also know that pain is poorly controlled in cancer patients and is often very complex with multiple features and challenging and refractory to different modalities of treatment which we may deploy. So depending on the definition, cancer survivors can either be patients who have completed their treatment or can be patients living with and beyond a diagnosis of cancer. And certainly for a large number of different tumour types, the survival rates have increased markedly over the last 50 years. And why is this? Well, we're seeing improved detection of cancer, so improved detection and screening and early diagnosis leads to improved treatment and better outcomes. And also the types of treatment we are able to deploy are rapidly advancing. We've seen the dawn of the age of immunotherapy, the use of targeted therapies, alongside chemotherapy for many tumour types now, and the development of robotic surgery, which means that tumours which 5 or 10 years ago were previously inoperable can now have surgical therapy with resection margins which lead to either cure or a period of remission. We're also seeing huge advances in the technology used in radiotherapy. For example, at the Royal Marsden site in Sutton in Surrey, we've recently built a MRI-guided LINAC, which means that radiotherapy can be targeted far more precisely than previously. Again, meaning that tumours which were previously unable to be treated can now be treated with radiotherapy. So what these advances have resulted in is a change in the way that cancer, and indeed cancer pain, is being managed, from a one-size-fits-all approach to a personalised, bespoke approach, using multiple different specialties working together in a team, but which compared to the previous approach is time-consuming, expensive and resource-heavy. So this rapidly increasing population of cancer survivors is met by a number of challenges, both psychological, physical, and social. And we know that amongst the physical needs that patients in the survivorship group experience, pain is a major challenge. In 2017, the National Cancer Research Institute held a scoping roundtable exercise and questioned over 3,000 cancer survivors about what their research priorities were, and pain was identified as a top 10 research priority. Interestingly, the number one priority was actually fatigue, and certainly in my clinics, patients often report fatigue as being equally or more bothersome than persistent pain. So why do cancer survivors experience pain? Well, one of the most common causes is disease-related pain. And if we think about our archetype of pain in a cancer patient, it is a tumour destroying tissue surrounding it, compressing nerves in proximity to the tumour, for example in this Pancoast tumour. And we know that many tumour types are closely related to complex or large nerve plexuses, which can be easily affected. The concept of a tumour is rapidly evolving from a simple bunch of replicating cells to a much more nuanced and complex structure. And we understand now that tumour does not just comprise the malignant cells at its heart, but also a surrounding stroma of supporting actors in the disease process. And these include inflammatory cells, which are attracted to the site by chemoattractic molecules released by the tumour cells, but also fibroblasts and nerve cells, which grow into the microenvironment, attracted by neurotrophic substances such as nerve growth factor released by tumour cells. And we know that there's a complex interaction between the tumour cells themselves and the surrounding cells in that tumour microenvironment, with this crosstalk between the different cell types. So the tumour doesn't just sit there in isolation, it's the puppet master of a huge array of different cells within this area. We also know, and we're seeing more and more evidence, certainly in animal models, that denervating tumours can lead to retardation of their growth.
So sorry, everyone. I think we're just having a little slight trouble with that video. We're just trying to get that back on working.
And we understand now that tumour does not just
We can play primarily, it doesn't matter. We have enough time, John.
And we understand now that tumour does not just comprise the malignant cells at its heart, but also a surrounding stroma of supporting actors in the disease process. And these include inflammatory cells, which are attracted to the site by chemoattractic molecules released by the tumour cells, but also fibroblasts and nerve cells, which grow into the microenvironment, attracted by neurotrophic substances such as nerve growth factor released by tumour cells. And we know that there's a complex interaction between the tumour cells themselves and the surrounding cells in that tumour microenvironment, with this crosstalk between the different cell types. So the tumour doesn't just sit there in isolation, it's the puppet master of a huge array of different cells within this area. We also know, and we're seeing more and more evidence, certainly in animal models, that denervating tumours can lead to retardation of their growth.
I think we had issue at the same point last time, isn't it? Audio.
It is. I can only surmise it's the presentation itself.
Matt, are you there? I wonder if you would be able to kind of go through this talk. Are you able to talk with us doing the slides in the background? I don't know if you're able to talk there from where you are. Doesn't look like Matt's there.
Matt is online. I have shared him as a co-host.
Yeah, there's no audio, I think, in his talk. I think maybe the talk was shared, maybe. It doesn't look like there's an audio later on, maybe.
No.
I think Matt's just around, so I wonder if we just wait a couple of minutes and see if he can help us out of this.
Yeah, we have time as well, you know.
Shall I try and share it one more time?
I think the audio is not there. I think in the later part, I've seen check the presentation. So
Right.
yeah, there is no audio. So you won't have audio even if you share. I don't see the audio button in the presentation in that slide. Yeah, so there's no audio.
No.
Other option is that I try to present it on his behalf, but if he's around, it's better if he can just do his slides, maybe if it's possible. But I think I wouldn't want to do the presentation for myself for his slides. I think it's better that he does if we can.
Yeah, he seems to have disappeared off the participants.
Yeah, I think he's on holiday now.
Yeah, maybe he's having trouble.
Right, shall we try and skip to the next speaker by any chance? Is that a possibility?
I think that will be next session, Sanjeeva. That will be next session, because we don't have any other talk in this session.
I think if Chris is not there, if it's not recorded, maybe we should go to the next speaker and see if Chris comes back a little later.
Matt, it's Matthew Brown.
Sorry, Matt. I'm sorry, I was talking. to
I
Chris.
think Matt's he's obviously he's currently on holiday, but he's I've just spoken to him on the telephone, and he's just kind of linking up his phone and things, and he says that he'd be happy to kind of carry on the presentation from with the slides in the background. But I think it's you know how it is when you
Yeah,
I think he's probably at the moment just getting his IT a little bit sorted out. I think it'll probably be a few minutes.
I think that's fine. I think
Yeah.
I think that's okay. So
I think that might be the best option, just to wait a short period, to be honest. And
while we are waiting, if there are any questions from the morning session, people can post it probably. You use that time in some useful way. Is that okay, Manor?
yeah, absolutely fine. I'm sure, Sanjeeva, you will have some
The
questions.
audience can be kept
So-
engaged. Shall I start a question to you then, Manor?
I know, I thought that was my concern, but go on.
Is that okay, John, as the organizer?
absolutely, yeah. Let's
Yeah, go for it.
Manohar, I think I
Yeah.
asked, but because you picked up. In your study, did anybody use dexamethasone instead of Kenalog? And what is your view on using dexamethasone or triamcinolone, considering the risks associated with particular steroid for transforaminals?
See, 2011, 12, and around 15, there was a shift happening nationally, internationally about particulate to non-particulate. So I was still using particulate at that time, but I was using with a digital subtraction imaging. And so I used Kenalog for the study because I somehow felt that Kenalog works better. That's my personal view, dexamethasone. But this study actually had, it's a pragmatic study. So there were patients who were offered dexamethasone in other centers. So there was a range of drug choices. So there were some patients who had dex in this trial. My view was that there was a trial published by German et al. And CIS trial with Nick Bogduk and German in 2010 pain medicine. They used triamcinolone 40 to 60 milligram, 40 to 80 milligram in that trial in ARCT and double-blind fashion. So I used particulate and with the DSA. But if I didn't have DSA, I probably would have gone for dex at that time because shift was happening. So my view, current view is that I think it's okay to use dexamethasone now, but we did not study Kenalog. So we didn't study dexamethasone in that study. It was pragmatic, but most patients got Kenalog in that study.
Thank you.
Manohar, also I'm just with the pre-ganglionic and post-ganglionic injection, and what made you choose the post-ganglionic site as to do the injection?
I think that's if those who do transfemoral epidural injections, the typical approach, with the transfemoral, you are in the foramen, sort of superior and posterior part of the foramen, sort of. So if you inject a contrast, typical contrast spread pattern is it goes around the pedicle and goes cranial.
Right.
That's the most typical contrast spread pattern. So if you have L5S1 disc and you do L5 root block for that patient, that will be preganglionic, but your contrast misses your L5 root and disc, it goes around, pedicle of L5 and goes cranial.
Sure.
So it doesn't stay at that level, that the disc level. So that's why I think my preference was to go post-ganglionic and get the contrast to spread at the disc level. Right. If I struggle with that, then I will go, preganglionic. Saying that, we did not have much issue if my colleagues wanted to use preganglionic, but we stipulated post-ganglionic. But again, equally, we were okay if they wanted to use a preganglionic, making sure that contrast spread was okay at that level.
So, Matt, it looks like Matt's here in his car.
Yeah, in his car. Yeah,
I'm
fantastic.
Sorry, guys. I'm ready to go. Apologies for the technical glitch. let me just share my screen. Where are we?
Take your time, Matt. I mean, we are delighted that you're able to, you can manage it. You've never done that in a car in a holiday doing a presentation, but thank you.
I'm ironically in the north of England as well. Let me see. Right, can you see that?
Yeah, you can.
Great.
And we
So
can-
I
we
think
can-
you got. Can you hear me?
Absolutely, absolutely.
Right. Okay. Cool. I am joining you from a service station in the north of England. Apologies for the technical glitch. So my name's Matt, consultant in pain medicine at the Royal Marsden. So I was tasked with talking about pain and cancer survivors. I think the talk looks like it cut out where I was just talking about some of the work that we're doing on trying to elucidate some of the links between the metabolic phenotype of tumors and the kind of pain phenotypes that patients present with. And there's a paper that's just been submitted to PNAS looking at that specifically in breast cancer. So watch this space. What I'm going to do now to catch up time really is whiz through the different types of pain that we encounter in the survivorship population, and there'll be time at the end for questions. I'm sure Manohar will organise that. So the first type of pain that we encounter in this patient population is pain related to treatment. So if you think about the major types of treatment that we encounter in these patients, chemotherapy provides a bedrock to most oncological management, and chemotherapy-induced peripheral neuropathy is incredibly common, affecting between 10 and 100% of patients, which depends on the agent used. And while central effects can occur, predominantly this is a peripheral sensory neuropathy, and it manifests with a classic glove and stocking length dependent features. And these can be divided into gain of function features, which are termed somewhat ironically positive symptoms. So things like very unpleasant pins and needles. And when people talk about pins and needles, it always makes it sound sort of downplays how bothersome that can be. But what patients often describe is, imagine when you wake up at night with a dead arm or leg, and imagine having that all the time with that really horrible kind of numb, but with the sort of white noise paresthesia present all the time. And also pain. So commonly this is described as a burning pain, but also a lot of patients experience allodynia. And this is often combined with negative symptoms. So things like numbness, loss of proprioception, which obviously has a big impact on patients' balance, loss of fine motor function. So if it's occurring in the hands, then the ability to, for example, do buttons or use the knife and fork. So it can have a big impact on quality of life. And areflexia, which those of you who are paying attention will know that that isn't actually a small fiber neuropathy. That's a beta fibers, which are actually myelinated. So why is this important in the context of oncology patients? Well, often the neurotoxicity is severe enough that it can either cause a reduction or require a reduction in the amount of chemotherapy that's given, or actually result in dose cessation. So why is this happening? Well, what's happening within the epidermis and dermis is that there's dieback of small fibers from the epidermis. And this is actually a slide on the left from a normal subject. It's actually me, so it's debatable if it's normal or not. But if you take a small 3mm punch biopsy of the skin and then stain it up using immunohistochemistry, you can actually define the small fibers crossing over from the dermis, which is below the white dotted line, across into the epidermis. And you can see that there's this dense plexus of nerves within the epidermis itself. And you can see in B, this is a patient with a chemotherapy-induced neuropathy. And there's been a real dieback of those epidermal nerve fibers. And in the dermis itself, what you're seeing is a dysfunctional plexus of nerves that are able to fire off at much lower thresholds than normal. And this explains why patients get this duality of symptoms, the negative symptoms due to the dieback, but also the positive symptoms because you've still got these hypersensitive nerve endings within the dermis itself. And this occurs for a number of reasons, often a combination of both disruption of microtubules, which you'll know are really important in axoplasmic flow, so that process whereby neurons are able to get substances from the cell body, which is in the dorsal root ganglion, out to the distal part of the nerve. But also there's a direct toxic effect on the mitochondria within nerve fibers. And what this results in is a reduction in the amount of ATP within the nerve, and the sodium potassium ATPase pump then isn't able to work, and you get swelling and damage to the nerve fibers themselves. We also think that there's a neuroimmune process at work, both peripherally and within the DRG and the spinal cord, whereby inflammatory cells such as Langerhans cells or microglia are attracted into the site of neuronal dysfunction, and this leads to further cell damage. So it's quite a complex process that's going on. People often ask if chemotherapy-induced neuropathy can occur with some of the more modern agents and approaches we're seeing in oncology, so things like targeted therapies and immunotherapy. And certainly in our practice, we are seeing a signal that patients having monoclonal antibodies can go on to develop neuropathies. And this is also mirrored in conditions where you get raised levels of monoclonal antibodies in the plasma. Patients do develop neuropathies as well. And this is related to the fact that these epidermal nerve fibers are basically living on a physiological knife edge, and any kind of disruption to their environment leads to dieback. So this is the kind of rogues gallery of chemotherapy agents associated with neuropathy. And you can see that it's all the favorites that we encounter day in, day out in oncological practice, the platinum-containing compounds, the taxanes, and then bortezomib, also known as Velcade, which is used in myeloma and is related to a very unpleasant, very dense neuropathy that patients develop when they're exposed to that agent. So another cause of pain that we encounter in the survivorship population is persistent post-surgical pain. It's little surprise that in the world of oncosurgery, there is a high risk of developing PPSP. There's a lot of very radical surgery that's undertaken with curative intent, and a lot of these patients go on to develop the very unpleasant and disabling symptoms of persistent post-surgical pain. The definition is slightly fluid, but this is probably the best one that's out there at the moment. It's important to note that persistent post-surgical pain can develop de novo after a period where acute pain has resolved. And often patients and indeed a lot of surgical colleagues find this slightly disturbing and confusing when a patient seems to have had a very, very good recovery trajectory and then re-present with pain and other sensory symptoms. It's important that other causes of pain need to be excluded during the initial workup of patients. And obviously the pain has to be related either directly or indirectly, as in being in the area of innervation of a nerve that traverses the surgical site before that diagnosis can be made. Again, this is the sort of top of the pops of types of surgery associated with persistent post-surgical pain, and you can see certainly in a comprehensive cancer center you'll be encountering a large number of these surgical approaches in day-to-day practice. So breast thoracotomy, which is a common approach for esophagectomies and upper GI work, also for lung cancer, and limb amputations, and we do a lot of these for sarcoma. We're one of the national sarcoma centres. You can see that caesarean section incision is actually missing off this league table and that is commonly associated with persistent post-surgical pain developing as well. So the clinical features of persistent post-surgical pain include many of the symptoms and signs that you'd expect to encounter in a neuropathic pain population. Persistent post-surgical pain doesn't fully meet the IAS definition of neuropathic pain, but certainly when you examine a patient with PPSP, you'll often encounter such features as scar hypersensitivity, allodynia, hyperalgesia. Probably the archetype of persistent post-surgical pain, certainly in the patients that I encounter, is persistent post-breast surgery pain. And this features a number of different sensory changes within the limb on the ipsilateral side of surgery. This is a brilliant paper from Lancet Neurology, where the Danish team basically delineated the changes that you encounter related to the area innervated by the intercostal brachial nerve, which you remember comes off the chest wall as a T2 nerve root origin, and then traverses the anterior axilla and innervates the inner upper arm with sensory innervation. And this nerve is often either sacrificed or skeletonized during both sentinel lymph node biopsy or axillary clearance, and this is thought to contribute to the clinical features of persistent post-breast surgery pain. So why do we get this this very disabling and unpleasant pain state arising in a proportion of patients? And it goes back to the processes that occur at the time of that initial surgical insult. And we know that when the scalpel or the diathermy hits the skin and the deeper tissues, it unleashes a stereotypical cascade of processes that leads to both changes in the periphery, so local reflexes attracting inflammatory cells, a inflammatory process with an aim to enable the wound to heal, but also changes caused by this afferent barrage within the cell bodies of the sensory nerves, so changes in gene expression in the DRG, and also changes in the dorsal horn in a proportion of patients with attraction of the good old microglia into that region. And it is thought that in a proportion of patients that develop persistent post-surgical pain, this is what is instigating that process, and why you can get that kind of time lag between the acute pain and the persistent pain developing. The risks of developing persistent post-surgical pain are diverse and numerous, and are related both to patient factors, so psychological morbidity, preceding traits of pain catastrophization, pre-existing persistent pain states, but also surgical factors, including duration of surgery, the use of drains, and interestingly, performing surgery in high throughput centers versus low throughput centers. High throughput are lower risk. So there's this hugely complex miasma of different factors that play into the development of persistent post-surgical pain. That diagram always reminds me of this thing that's in our coffee room at work, and it just sums up how complex the factors are that contribute to the development of persistent post-surgical pain, and probably explain why the search for a kind of silver bullet intervention to prevent or reduce its development has so far not been particularly fruitful. One thing that's really interesting about persistent post-surgical pain is that you can pretty reliably risk stratify patients for its development, especially in breast surgery. This is a lot of work done by a team, an international team, including researchers in the UK, the Scandinavian countries, and Scotland. And they were able to build a predictive model for patients, the likelihood of patients to go on to develop persistent post-surgical pain. You can see that the presence of preoperative pain, being obese, having surgery in the axilla, and relatively poorly controlled acute pain are all risk factors to go on to develop persistent post-surgical pain. There's been a lot of interest in what can actually be done in the perioperative period. And as I alluded to earlier, it's unlikely that there will be a single silver bullet intervention. What we know is that actually work on streamlining the perioperative process, ensuring that simple things that should be done are done, like managing acute pain well, looking at using a regional anesthetic technique to try and reduce the afferent barrage, trying to optimize psychological well-being, are all worth doing, but often are challenging in a stressed healthcare system, which certainly with oncological surgery is trying to operate on very short timescales. Trying to get somebody's severe anxiety and depression managed within 2 weeks is often quite challenging. Cancer-induced bone pain it remains a significant problem in the survivorship population. It's common and is seen in a number of different tumor types, commonly breast, lung, prostate, but also in primary bone cancers, and commonly manifests in long bones and the axial skeleton. It really is a very unpleasant pain to experience as a patient. There are three facets to this pain. Background gnawing pain that's constantly present, reminding the patient that they've got bone cancer. Often patients get incident pain, so when they try and mobilize or put force through their bones, they get a flare-up of pain, and also spontaneous pain secondary to the changes in innervation that occur in the periosteum. If you had to design a pain generator, you'd probably come up with something a bit like a bone metastases. It really is quite an evil thing. The tumor cells lodge within the bone marrow, which, as you know, has an incredibly rich blood supply, and they essentially hijack normal bone homeostasis by secreting a number of signaling molecules that take over osteoclast activity and drive it. They also manipulate osteoblast functions, so you get aberrant remodeling of bone. This explains why patients get pathological fractures, because the bone that is laid down is low quality. The bone, the bone metastases cells also release nerve growth factor into the periosteum, which causes a sprouting of small nerve fibers into the periosteum and microneuroma, and these have a much lower threshold to fire off, and combine this with the fact that osteoclasts are releasing hydrogen ions into their environment, you've got an incredibly potent mix of factors that can cause pain. This is a brilliant and really elegant experiment done by a team led by Pat Manti in Texas. What they did was develop a bone model in an animal and were able to stain up, and you can see this in B and E, the aberrant growth of nerve cells within the periosteum. They were then able to expose the animals to an anti-nerve growth factor monoclonal antibody, and were able to block the development of these microneuromas, thereby demonstrating that it was nerve growth factor that was driving this process. An interesting type of pain that we see in patients in cancer survivors is aromatase inhibitor induced arthralgia. And this is seen in patients having hormonal manipulation in breast cancer patients. And aromatase inhibitors essentially block the production of estrogen and is used in patients with estrogen receptor positive tumors. It's common, it occurs in about 74% of patients and presents with an arthralgia rather than an arthritis. So patients get joint stiffness. The common thing that patients say to me is, I feel like a 90-year-old woman. And patients find that when they wake up in the morning, it's quite hard to get out of bed. It sort of eases over the course of the day, but it's very disabling, and it doesn't respond well to simple analgesia. The pathogenesis remains unclear. We know that estrogen receptors are involved in synovial membrane function, and plasma vitamin D levels seem to be related to the development of the symptoms. What we know is that the management, or the evidence for management, isn't particularly good, and there's some evidence that duloxetine might be helpful, and acupuncture, and also maintaining a supranormal vitamin D level. So very quickly, what are the management approaches in the survivorship population? Well, in essence, it doesn't differ hugely from the management of any persistent pain group. There's obviously a sort of section that needs to be bolted on to the history because they are an oncology patient, and understanding the patient's cancer journey. So what treatment have they had? What kind of follow-up is planned? What imaging is available? And always have that little voice in the back of your mind thinking, could this represent recurrence? Obviously examining the patient, focusing on sensory change and delineating any areas of sensory change that may be present in certain pain states, looking at relevant imaging, and exploring the psychosocial situation. In patients with advanced cancer, there's this concept of total pain, where pain is actually used as a to express other distress. So psychological distress can be expressed as physical pain. The goal in survivors is to optimize functional levels, and there's a lot of work and interest now on value-based rehab, where instead of a clinician or a team identifying rehab goals, looking at what the patient wishes to rehab towards is more potent. Introducing targeted agents with regular review and up titration is also important, as well as taking a multidisciplinary approach. And we're very lucky in our hospital to run a weekly multidisciplinary team meeting with palliative care, psychology, physio, and pharmacy. And we try and get our oncology team involved. There's a huge amount of guidance available, both from bodies such as the Faculty of Pain Medicine, but also some brilliant guidance that Manohar was involved in, published by the European Society of Medical Oncology, and also this document, the Framework for Provision of Services for Adults Across the UK with Cancer or Life-Limiting Disease. It's a bit of a mouthful, don't try and say that after a couple of glasses of milk, but that again is a very useful document which lays out the different levels of pain service which should be available for patients in the UK. You'll all be familiar with the WHO step ladder, or steps on the introduction and up titration of analgesic agents. This guidance was developed for oncology patients. It's subsequently been hijacked into non-malignant pain, but in a oncology population, this is the correct approach to take. And it's important to note that if you move up a step, you're not stopping the agents in the lower step. You're merely using them to augment the next level of analgesia. Certainly for patients with neuropathic pain features, there's very good guidance out there from the NEPG of IASP, so the Neuropathic Pain Special Interest Group, which provides guidance on up titration of agents in the context of neuropathic pain and features of neuropathic pain. And as with any intervention in pain medicine, it's a case of trying to find a balance between side effects, the tolerability of agents, the efficacy of the intervention itself, and the practicality of delivering these interventions in a population that often are trying to rehabilitate and reduce their footfall through hospital, because quite frankly, most cancer survivors do not want to spend lots and lots of time engaging with healthcare. They want to be rehabilitating and getting on with their lives. So in summary, we know that pain in cancer survivors is common, severe and challenging to treat, and that the pain we encounter in this patient population can be due both to disease and its treatments. The population of cancer survivors we know is increasing rapidly across the globe, and the burden of pain in these patients will therefore also increase. And that successful management of these patients requires a comprehensive assessment and a personalized treatment plan, which aligns with oncological management. There's a huge drive now towards personalized management in this patient population. And I'm confident that pain medicine will play a key role going forward in the ongoing rehabilitation of cancer survivors. So once again, sorry for the issues with the presentation before. I'm very happy to take any questions now. And my email is on the front of the presentation. So if anyone wants to get in touch offline to discuss anything, I'm very happy to be contacted as well. Thank you very much.
Thank you, Matt. I think it's really excellent presentation, and we also had a presentation this morning on functional neurological disorder. But you really made a good sense of mechanisms of pain in cancer survivors and why they get the pain. So it was really interesting that you highlighted so many different ways pain could come about, and also aromatase inhibitor, related arthralgia, which you said is nearly 70% or 75% incidence. So thank you for excellent talk. I really enjoyed it. And there are some questions, if I can ask you. There are some comments as well. One comment is about that what proportion of work you have is cancer related. This is just a kind of a interesting question, but I'll let you answer that.
Yeah, so I do 100% cancer related pain. The hospital I work at just does cancer.
Okay, thank you. So second was that you mentioned briefly mentioned supranormal vitamin D levels. You mentioned that because it's very difficult and challenging, that arthralgia type pain which you get in these patients. So what did you mean by that, or is there a level, or is there a sort of way to actually quantify it? Hello? Matt, I think you're muted. Can you hear me?
I think he's done particularly well to be survive this long. Really, he was in the back of his car. I wonder whether he's just lost the. We've lost him for a second. I think.
No, I thought maybe I'm lost. So yeah. You can hear me, okay?
Yeah.
Probably he'll come back. Yeah.
I wonder whether he's yeah.
Okay.
That might be it from him.
So there was another comment from one of the delegates that they get very good results in their practice with cancer survivors with high dose capsaicin patch. So I presume that I wanted to check with Matt, but I suspect that this must be to do with either a peripheral neuropathic pain or post-surgical, post-treatment, scar-related neuropathic pain, persistent post-surgical pain. So maybe that's what it is. And I think probably we'll all agree with that it does have a role, a very significant role in those cancer survivors. So I wanted to see, maybe he lost a signal, and maybe I think it's good that he lost signal now rather than during the talk. I mean, in one sense.
I think
so
he
I'm
did.
sure he'll come back.
Hi, I'm back. Sorry.
Okay. So Matt, are you back? Yeah.
Yeah, I'm back. Sorry about that.
So thank you. So thank you for coming back. You mentioned, Matt, in your talk about supranormal vitamin D levels. Can you clarify a bit more as to what did you mean by that?
Yeah, there. To take a step back, Manohar, with aromatase inhibitor-induced arthralgia, there's very little work published in this area, and one small observational study basically showed that patients with high normal vitamin D levels had a lower incidence of development of aromatase inhibitor-induced arthralgia. So what we do in our clinic, if we see patients with this, is we'll do a vitamin D test, and if it's low, then we'll supplement up to high normal, basically. So that's what I meant.
Okay, no, that's very helpful, because so you wouldn't stop at normal range. You'll try to push it to the higher sort of range of normal. No, that's very helpful to know, actually.
Yeah.
Okay.
And the other thing we do is we get them a course of acupuncture as well.
Okay, so that's great. Yeah, thank you. So the other question was about anti-nerve growth factors for bone pain.
Yeah, so things like denosumab and tanezumab. The issue with tanezumab was that and I'm sure everyone's aware of the story of its development for use in osteoarthritis, and it was basically associated in the phase 3, I think it was, initial studies with basically people developed something similar to avascular necrosis, and then it basically they had to redesign the studies, requiring serial imaging for patients on those studies. And my understanding is that the FDA have recently basically said that it's not approved for use in clinical use in America for osteoarthritis. I think there are some studies going on in its use in bone metastases, but we're not involved as a center in those studies. But if you look on clinicaltrials.gov, it looked like there were some studies going on globally.
Okay, yeah, no, thank you. I think you had a really comprehensive talk, Matt. There was other comment, I think when you were just sort of lost with the net connection. Capsaicin patch, one of the delegates mentioned that they get very good results in the cancer survivors with high dose capsaicin patch. So what's your view on that?
Yeah, so we're, because of the way pain is commissioned in London, we don't do capsaicin patches, but we do send patients to our colleagues at Chelsea and Westminster for consideration of capsaicin patches. And the two groups that we will send are chemotherapy-induced neuropathy patients who've basically proved refractory to other, topical treatments and other systemic agents, and also patients with persistent post-surgical pain, particularly things like thoracotomy pain, and also post-herpetic neuralgia. And they'll follow a pathway where we trial the least or less invasive interventions, and then we'll consider referring them on. So yes, we do use that, but we physically don't apply them in our trust because we're not commissioned to do it, basically.
Sorry, thank you. May I ask you more questions? Is that okay with you, Matt? Yeah.
Yeah, of course. Yeah.
This. Do you use Botox then? Botox injections?
Yeah.
So can you just mention a bit? Explain.
Yeah. So what we do is we use subcutaneous Botox for patients, again, with localized neuropathic pain. The three big groups are, I mentioned at the start the bortezomib chemotherapy-induced neuropathy. Often they get a really nasty, painful neuropathy in their feet. So we often end up doing subcutaneous Botox on those patients. If you want the kind of recipe to do this, if you Google the BOTNEP, so it's BOTNEP study, which was led by Nadine et al., who's a French pain clinician who a lot of people have heard of. there's a really nice kind of recipe there on how to do it. And as I said before, if anyone wants to ask questions offline, just drop me an email and I'll just get back to you. But in a nutshell, we basically mark a grid out on the painful area. We apply EMLA, plus or minus some cold spray at the time of injection, and then we inject 5 international unit blebs under the skin in a grid pattern. And in patients that it works in, you then get about a 2.5-3 month window where you get a reduction in allodynia. You actually get a kind of shrinking of the area that's you've got the unpleasant sensory change in. So that's it in a nutshell, but I'm very happy to be contacted.
Thank you. No, I think it's really interesting and helpful, and share your experience, because we
totally
struggle with pain management options for this patient otherwise. So I think whatever we can have, I think it's important to share that. So thank you for that. I got one more question coming through. So somebody asked the question that what percentage of your cancer survivor get pain intervention? So I don't know what they mean by pain intervention. So can you see how you can answer that?
I guess if you're thinking, a needle-based intervention, that's relatively low. But to me, an intervention would be number one, being seen in the clinic and being assessed in a multidisciplinary context. And as I said in my talk, a lot of these patients, they just want to be rehabilitated. They need advice and pointers on how to do that and support to do it. And I think pain medicine, actually, as clinicians, we're very good at, we understand the context and the medical environment those patients are in, and we're very good at signposting and referring on to other allied health professions, other specialties. And I think we're very efficient at doing that. And I think that actually that's what we bring to the table. As far as interventions are concerned, things like spinal cord stimulators or intrathecal pumps, by definition, they're right up at the top of the tree. And really, you should only be doing those in a small, well demarcated group of patients, right? And actually, the bread and butter of our work should be supporting that kind of rehabilitation of patients. And I think that's what we try and do. And I think that's what most pain centres across the UK are very good at doing.
Thank you, Matt. I think it was really nice, to have you on this, meeting, and to have the pleasure of it was almost like a highlight of the meeting, and also having a treat for all those attending. So I'd like to thank you for making it a point that you presented it, and I hope your holidays goes very well, because it's just, I hope it is.
Thank you. I've been in the north. I've been in the north of England, and it's been really lovely. So thank you, and thank you very much for inviting me. And I hope the rest of the day goes well.
Yeah, thank you, Matt.
Cheers. Take care. Bye.